Hi, welcome. This is session 252 with Dr. Busaidy. She is an endocrinologist and associate professor in the Department of Endocrine Neoplasia and Hormonal Disorders at the University of Texas and the Anderson Cancer Center in Houston, Texas. Dr. Busaidy is the director of the Thyroid Nodule Clinic, specializes in thyroid cancer, and has authored numerous peer-reviewed research articles and book chapters. Dr. Busaidy is a recipient of a ThyCa Thyroid Cancer Research Grant and has spoken at many ThyCa conferences. She is a ThyCa medical advisor and a 2011 ThyCa Research Grant recipient. Thank you, Dr. Busaidy.
Good afternoon, everyone. Hopefully everyone's enjoying the ThyCa meeting so far. It looks very exciting, and I've been having fun so far, and the biggest attendance ever, so that's great. So in this session, what I'd like to do is I'm going to make it fairly interactive once we get through our slides, only because it's on, it's on Zoom. So I think I'll get through all my slides, and then we'll open it up for questions, and you can type them in the Q&A and we can go over them. Because I think it's going to be usually when I do this in person, I like to make it interactive and allow questions throughout, but I think it's a little bit harder in the hybrid. So we'll do them all at the end. And yes, we can take personal questions, but let's talk about some general concepts in the beginning and what research there is about this topic. So this was a little bit of a broad topic, but I broke it down into, the question is basically, do I have the right medical team for me? When is a second opinion? When's the right time for it? And then separate from that is, when do I actually need an oncologist? Is an oncologist part of the thyroid cancer team or not, right? So those are sort of the things we're going to delve into. So let's start with, who is a thyroid cancer patient's medical team, right? There can be many, many different people. Oftentimes, a lot of patients' thyroid cancer was found by a screening ultrasound that was done at some church fair, right? Or like your workplace, and they found nodules, and that's, how it happened. And a lot of times it starts with the primary care doctor. So all these people are part of your team, right? The main person in general for the majority of patients who have thyroid cancer is an endocrinologist, and we're going to define that. And typically the patient gets at least a surgical opinion, even if they don't have surgery. So a surgeon is usually part of the team. And that surgeon could be a head and neck surgeon, could be an ENT surgeon, could be a general surgeon, could be an endocrine surgeon. There are many, or oncologic surgeon. There's different subspecialties within surgery, right? And then a radiation oncologist sometimes is involved. And we'll talk a little bit about that, whether they need external beam or traditional radiation, or radioactive iodine sometimes is given by radiation oncologists. And then an oncologist typically, for the most part, comes in when somebody has more advanced disease or needs systemic therapy. But in some patients' cases, depending on where you live, an oncologist may have been treating the patient with thyroid cancer from the beginning. That's more rare, but is possible, right? So you never have the wrong doctor. A medical team can consist of any of these people. Now, in more advanced disease, you may see some other subspecialties, which are not listed here. I'm talking about for the vast majority of people with thyroid cancer. Okay. So what is a second opinion, right? So the definition in the Merriam-Webster was that the second opinion is the opinion of a doctor other than the patient's current doctor, okay? And if you're like my doctor, if you're like my daughter, she looked at me when she was always curious about what talk I'm giving, and is interested because she gives me good feedback. And she was like, why would anybody ever need, right, another opinion, another doctor? Now, she's been blessed with great doctors her whole life, right? So it didn't even occur to her that people go to another doctor for another opinion, right? So why would anyone ever do that? And when is it called for, right? Or even in Barb's words, a third or a fourth opinion. So I like Dr. Grauer from Yale said it nicely. Second opinions are good when there is not a perfect answer for you and you want more input, right? Simple as that. It doesn't have to be more complicated. It doesn't have to have further definition. You're just not comfortable, right? Or you want more. If your gut tells you something is not right, and never feel like you have to agree to a treatment, especially if it's morbid or complicated, and if you're uncomfortable at all, right? You never have to agree. You are the one who's consenting. We are blessed, in the United States, especially in this country, that you are the one who decides. At the end of the day, it's your consent. So remember that you always have options. You always have choices. And I put a couple of caveats to that. But second opinions are anytime you're uncomfortable or you want more. So second opinions are good anytime, but specifically anytime a patient is uncomfortable with their doctor, right? Whether it's what they're hearing or how it's said or a personality difference, or if the treatment plan just sounds off or not what you read. It doesn't mean that you are right and the doctor's wrong. You are the patient being treated and are somewhat uncomfortable, or it's different from what you expected, right? Second opinions are also good if you have a rare disease, or if the treatment sounds morbid, or just because you feel like it, right? Simple as that. And people try to make this very complicated and make it about them, especially physicians. This isn't about the physician. This is about the healthcare team in general. This is about the patient. Nobody needs to be hurt. If you want another opinion, please get another opinion. Now, second opinions are definitely encouraged in specific cases, right? So if you have a rare tumor, right, that means that people don't always know the answer, right? Or there may be more than one answer. And when you look at the guidelines on thyroid cancer, first of all thyroid cancers are rare, period, end, right? But especially thyroid cancers that have advanced disease, right? Especially patients with anaplastic thyroid cancer, patients with medullary thyroid cancer, because remember I showed you, well, sorry, that was my last talk. You've heard it in other talks, 1% of all cancers are anaplastic, 4% of all medullary thyroid cancers. I'm sorry, if all thyroid cancers are medullary thyroid cancer. So those by definition are rare, right? Especially if all thyroid cancers are rare. If you have differentiated thyroid cancer and it's radioactive iodine refractory and progressing, or you've had multiple surgeries, right? Those are all rare and second opinions are encouraged. If you've had multiple surgeries and then you're like, why does this tumor keep coming back? What's going on, right? It may be time for another opinion. It doesn't mean your doctor is wrong. Second opinions do not mean that you do not trust your doctor. It doesn't mean that they're wrong. It means that you want to make sure you're getting the right treatment. And a second opinion is encouraged anytime you're uncomfortable. So what are some facts and caveats to second opinions? Well, you do just always remember, you do have a right to a second opinion, and your health plan needs to agree in general to the idea of a second opinion, okay? And your health plan has a right to ask you to get a second opinion before agreeing to a treatment. So sometimes it comes at their request, sometimes it comes at your request, right? The caveats are that you have to be able to afford it, because sometimes to get the second opinion you want, you have to travel, right? So that may involve, right, flights, hotels, time away, et cetera. So it's not simple by any means. When I'm saying, if you're uncomfortable, get a second opinion, I do realize that it's not as easy as it sounds. And sometimes the health plan, so the health plan has to agree to a second opinion, but they don't have to agree to the opinion you want, right? Where you want it, who you want it with, they don't have to agree to that. So those are the caveats. So just because you go see another doctor for a second opinion does not mean that you do not like your doctor, nor does it mean that you don't trust your current doctor. So for example, you come to see me and you're not comfortable with what I'm saying, or it doesn't sound right, or you don't like my personality, or it just doesn't jive, or it's too hard to keep coming to me. Any of those are fine. My feelings should not, number one, dictate how you feel, meaning about getting another opinion. And you don't need to worry, oh, I shouldn't ask them for medical records from Naifa Busaidy to go see John Smith because her feelings will be hurt. No, your medical records are your right. They are your property, right? And it's okay for you to tell me, hey, listen, I'm just going to go get a second opinion. Not because I don't trust you. I just want to get another opinion so I'm comfortable because I realize that this is advanced or whatever. Right? And it's okay. And if you don't want to tell me you're going to get an opinion, that's okay too. But I'm just saying, don't let that dictate. I see too many patients who they'll come to me and they'll be like, oh, I couldn't ask my doctor for their records because I was scared they would know. They don't know I'm coming for another opinion. It's okay if you don't want to tell them, but you don't need to be scared. Right? And it's okay if you come to somebody, go get another opinion, a second opinion, and then go back to your original doctor, right? And you can discuss, okay, I went and I saw so-and-so, and this is the treatment plan, but I'd like to stay with you. Or it's okay for you not to go back to that one and change to a new one, right? No doctor, not the first nor the second, should be threatened by you wanting another opinion. Your doctor should want you to be comfortable. And I can't emphasize this enough because I see it day in and day out, right? Nobody should make you uncomfortable because you make choices to make yourself comfortable. So what is some research on second opinion? I just picked this paper from 2019 that I thought was interesting and good, and it was not thyroid cancer specific, but it was found that a second opinion resulted in changes in diagnosis 15% of the time, right? That's high, right? Because even if it's 1% of the time and you're the one, right? But if it was 1%, you could say maybe that's chance. 15%, not chance. Treatment, second opinion resulted in treatment changes 37% of the time, or both 11% of the time. And so they concluded that the clinical impact of a second opinion was estimated as moderate or major in a fifth of the cases, 21% for diagnosis, and a third of the cases for treatment, right? Oh, now I'm generalizing there, but my point is, don't be afraid to get one. So that's all I had on second opinion, but we'll come through with questions afterwards. We'll move on to when should I see an oncologist, right? Now, when I was asked to talk about this, I made a few assumptions about why this question was asked. So I'm going to put that out there in case there are other reasons to be asked this question that I didn't think about. So if you have been seeing an endocrinologist, which most thyroid cancer patients see an endocrinologist, not all, but most, and you've seen a surgeon, and you have advanced disease, the question being asked here is, do I need an oncologist and when, right? Or that's how I understood the question. So let's talk about the definitions, right? What's an endocrinologist? What's an oncologist? Because they're all doctors, okay? So an endocrinologist is a physician who takes care of glands, okay? That's the definition of endocrine. Or hormones, right? So chemicals that move through your blood from one organ to another, issues in patients. So thyroid is a gland, and a very important one, because I'm a thyroidologist, right? So it's the most important gland in your body. So thyroid is a gland, and thyroid gland makes hormones, thyroid hormone. So therefore, an endocrinologist, thyroid issues and thyroid cancers are mostly treated by endocrinologists, right? It's just the fact of the matter of what it is around the world. Doesn't mean everyone has one, but most, okay? Now, most thyroid cancer patients have a low risk of recurrence. So what that means is that most thyroid cancer patients are treated by endocrinologists and remain with the endocrinologist for the rest of their life, right? They may not see anyone else other than a surgeon, but they may never see an oncologist, and that's okay. There are occasional patients, thyroid cancer patients, who start with an oncologist and remain with them, and that's okay too, but I would say if you look at the statistics, that's rare. I'm sorry, I misspelled oh, no, I didn't. Sorry. Radiation oncologists are people who treat tumors of all different kinds that need some sort of radiation, and hence the word in their name. Some radiation oncologists don't just treat with what we call external beam radiation, stereotactic radiation, and all these subtypes, but they also treat with radioactive iodine. So some of you may have seen a radiation oncologist to treat with radioactive iodine. Radioactive iodine otherwise is treated by nuclear medicine physicians or the endocrinologists themselves, right? So you don't have to have any one of these, but the vast majority of thyroid cancer patients are treated by endocrinologists. Now, what's an oncologist? An oncologist is a doctor who treats cancer, okay? Now there's slight definitions, some prevent, et cetera. But usually, oncologists will see thyroid cancer patients when they have more advanced disease, and someone is thinking in the near future or now that they need systemic therapy or targeted therapy. Again, that's not everybody. So I don't want you scared just because you're seeing an oncologist that it means you have advanced disease. It depends on the town you live in. Maybe there was no endocrinologist, right? Or maybe this oncologist likes treating thyroid cancer. But especially lower stage thyroid cancers typically don't see an oncologist. Okay, so those are the definitions. Now, when do you see an oncologist? Well, it depends. And you can see here, discuss with your care team, because everybody's an individual, cannot be underemphasized, okay? Now I put it 8 times on the slide, but I could have very well have put it 100 and made it circulating on a video, okay? Very important. You are an individual. Your thyroid cancer is a small part of what is, in your body or was in your body. And everything needs to be personalized. So talk to your care team if you need an oncologist or not. Now, in addition to discussing with your care team, some ideas of when you may need an oncologist is that if systemic or targeted therapy is being considered in the near future and your endocrinologist does not treat with systemic therapy. The reason I say that is an example, I'm trained as an endocrinologist. I did additional training in oncologic endocrinology. That isn't a very common subspecialty within endocrine. Okay, so a lot of endocrinologists, I treat with systemic therapy. I give immunotherapy, I give chemotherapy, I give targeted therapy. Okay. But if you look across the nation, across the world, the vast majority of endocrinologists don't treat with systemic therapy. So if you need systemic therapy, most of the time you will probably co-see, meaning you'll see your and continue to see endocrinologist and also see your oncologist who will be giving you your systemic therapy. Again, there's many endocrinologists, especially in the United States and even abroad, who treat patients with systemic therapy. So I'm not unique by any means, but what I'm saying is I'm talking in general terms, right? So if you have thyroid cancer that has distant metastases and your endocrinologist does not treat with systemic therapy, it may be worth asking to see an oncologist to establish the relationship. Now, another reason to see an oncologist is if your endocrinologist surgeon suggests, it means that there's something about your disease that they would like their opinion, right? And that they would like to have that. So, you know, when we talk about second opinion for, going back to second opinion for a second, for patients wanting a second opinion, think about how the healthcare world works. As physicians, we do what's called multidisciplinary conferences or tumor boards all the time. And even if we don't do it in a formal way at wherever you're seeing your doctor, we do it in an informal way. We go to each other and say, hey, what do you think about this case? Or looks, I have this patient with this. What do you think? So we are getting our own second opinions all the time, right? Every day, no matter whether you're in private practice and academics, whatever it is, you call a friend, you know, we all call each other for help because we're not God. We're not always right. And not everybody has the same type of tumor, right? So it's similar here. Maybe your endocrinologist and surgeon says, let's just get the opinion of oncologist. Doesn't mean you need systemic therapy now, but let's talk to them, right? Another reason you might see an oncologist is if you've had repeated surgeries and wondering, is there anything else targetable out there that's not so, you know, potentially complicated or morbid? And if your endocrinologist is not sure if there's something else out there, that may be a time you say, hey, should I be seeing an oncologist, right? And do you have one that you recommend? Because most of you have been with an endocrinologist for the vast majority of your life that you have had thyroid cancer. You trust them. So now that you're going to go see this oncologist, you know, you're going to have a little bit of, I'm not sure. Maybe they'll just be aggressive just because they have chemo, they want to give it to me, right? So you're going to question it. So it's important that you talk to your team and ask their thoughts, right? But it's okay for you to suggest it as well. And just because you see an oncologist doesn't mean you're going to end up on chemo. Now, if the decision has been made that you're going to be seeing an oncologist or it's recommended that you see one, then if you're potentially going to need an oncologist or it's anticipated, for example, within the next year, it's better to meet the new team member who's the oncologist in your team earlier. So it's not that, boom, as soon as I'm referred to one, I need to start chemo, right? Because you're going to hesitate. So if you establish that relationship, like, you know, you have some distant metastases, it's mildly progressing, let's just meet with them and follow along. You establish that relationship, gotten to know them. And then if you need the systemic therapy, you go forward, but you're still being managed with your endocrinologist along, right? You're not saying goodbye. Oncologists in general don't like that, you know, if you just come to them last minute as soon as you need therapy, the vast majority, not all, because patients aren't as trusting. For some of you, thyroid cancer, you've been followed for, you know, living with the disease for 20 years. And now you need systemic therapy and you're meeting a new doctor and suddenly they want to give it to you. And you're thinking, if you see a hammer, if you see a nail and you have a hammer, you're going to hammer it. So therefore, if you treat with chemo and I have thyroid cancer, you're going to treat me. So you're not as trusting, but establishing that relationship and seeing that this oncologist knows that not every time you have thyroid cancer means you give chemo, but we're okay watching it together because I'm not sure the right time. That's the ideal situation and team. So with that, we're going to leave the remaining 30 or 40 minutes for questions and open discussion, because I think this topic is important. And I see patients all the time that are not very comfortable with their treatment plan, but they're also not comfortable with getting a second opinion. And so I want y'all to be comfortable. And even if you're seeing me, I have no problem you going to get a second opinion, right? Because again, it's not about me, it's about you. All right, so Barb, I don't know if we have any questions yet, or if you want to start off the questions. I don't see anybody raising their hand yet.
Right, I don't see any questions in the Q&A either, or raising my hand, but I am going to throw my 2 cents worth in there too. I come from an urban area that has several med centers, and I'm going to say, if you get a second opinion, don't stay within network. Go out of network to get something different, because sometimes if you just go to your physician's friend down the hall or in the same plan, you'll get the same opinion. But maybe if you go to Kettering in one day and you go to Mercy the next, in our case, St. Louis U, it's a good idea to do get maybe different, even though they're supposed to follow the same standards of care. It's nice to get a different opinion that is actually from a different, group, so to speak. So go out of town and get one. It's worth a trip, maybe. So sorry, if anyone else have any questions or opinions, please jump in there. Thank you.
Agreed. And sometimes at these meetings, patients want to give you the scenario of their loved one or themselves. That would be okay too. Just know that if you're okay with that, it's a public setting. So if you want it as privately answered, you can put it in the questions, but say type only or something so that I know not to read it out loud. So we have a question. Thank you for this great topic. Thank you, John. What happens if your endocrinologist or surgeon does not agree with the oncologist? What is the percentage of care from each doctor? Yeah, so great question. So in other words, it sounds like this person themselves decided to go to an oncologist, or could have been referred to an oncologist, but then there's disagreement within the team, which actually does sometimes happen. Now, ideally, the team would have talked about that before you saw them, right? So in other words, let's say they referred you to an oncologist, or you told them, because ideally, full disclosure, you tell them, hey, I'm going to go see an oncologist and get their opinion. And you get the opinion, and then they talk and they say, this is what I'm thinking. What do you think? It's okay. They don't have to change each other's mind to all be, in agreement, but they should at least be on the same page what they're telling you, so you're not confused as the patient. It happens way too often that doctors are not talking, and then the patient walks away saying, like, what do I do, right? So you can encourage your oncologist, endocrinologist, and surgeon to have a conversation and talk to them and say, this is what I heard my oncologist say. It sounds like they're ready for chemo, but you had told me that it may be okay to wait. Is there a way you can talk to them to see what's the right time? And the reason, probably to be fair to the doctors, that there is disagreement is not because they're just lazy to talk to each other, but they're actually, a lot of thyroid cancer, especially in advanced disease, there is not agreement on what the right thing to do is. Right? You can look at the guidelines and what percentage of the guidelines actually says expert opinion, right? As opposed to, we have shown research and papers show blah, 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 blah. So a lot of what your doctors are doing many times is expert opinion, or people who see a lot of thyroid cancer have come together and said, this is what we're seeing, or these kind of publications show this, right? So there isn't a prescribed percentage of care from each doctor. To answer your question, in general, you're going to have this relationship with your endocrinologist or surgeon or somebody you've been with a long time, and then you get this new opinion and then try and put them together, but ideally have your doctors talk. And sometimes there isn't a right answer, and then you do have to decide. Is there such a thing as talking to an oncologist too early? Yeah, so that's a great question, Hugo. I don't know if there's such a thing as talking to an oncologist too early, but you probably don't need, if you're seeing an endocrinologist, or a surgeon, and you're already being treated for your thyroid cancer, and you don't have any evidence of disease, you probably don't need another doctor, right? And why do I say that? If you're talking about somebody who already has a great care team, and you have small spots of disease, and the oncologist that you have gone to see is somebody who's used to treating breast cancer or kidney cancer, and they don't know as much about thyroid cancer. In those other cancers, if disease is present in your body, you automatically go on treatment, right? In thyroid cancer, just because you see disease does not mean you go on treatment, because different from those other cancers, we don't have the cure, right? Our systemic therapies are drugs that slow the tumor from growing or shrink the tumor, but don't completely get rid of it. Other than surgery, there's no cure, right? So sometimes if you go to an oncologist who isn't as familiar with watch and wait approach in thyroid cancer, and you see one, they may suggest systemic therapy too early, Okay, so it's not that there's a time that's too early. It depends on, who you're seeing. So you have to, be careful and go back to the one you trust, and say, hey, my oncologist is suggesting systemic therapy, but I read blah, 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 blah. So the informed patient is key. So no, there isn't such a thing, but yes, there is, in the sense that make sure the oncologist you're seeing knows about thyroid cancer, and that there is such a thing as a watch and wait approach. And it's okay for, being well-read, seeing the doctor and going from there, right? And questioning them, challenging them gently, right? Don't be like, that's not what WebMD said, right? I mean, don't insult your doctor, just let them know. I'm in remission from anaplastic cancer. Congratulations, that's awesome. And have always been treated by oncologists. Do I need an endocrinologist? So anaplastic thyroid cancer may be that exception to the thyroid cancers where many of the patients with anaplastic thyroid cancer see oncologists only and don't even have an endocrinologist. They may have started with an endocrinologist, but most endocrinologists are not treating anaplastic thyroid cancer by itself, right? The exception to that is the endocrinologist who gives systemic therapy. So you are probably okay as a patient with anaplastic thyroid cancer, not having seen an endocrinologist or, or any thyroid cancer, but especially, you're in remission and doing well. If your thyroid hormone levels are in the normal range, it's not that you have to have an endocrinologist. Why are so many endocrinologists not empathetic to the life-altering impact of cancer and still acting like it is a good cancer? Patty, I am 150%, if so there's such a number, with you, right? It's not just endocrinologists, it's oncologists, it's surgeons. Too many people say thyroid cancer is the good cancer. Oh my God, if you had to have any cancer, thyroid cancer, the one I want. Well, number one, nobody wants cancer. Number two, you don't know if I'm going to be in that 5 to 15% that it recurs in and it affects my life. Number three, the primary treatment, even if it never comes back, may affect my quality of life. So just don't say it, right? And I think sometimes, to be fair to those physicians, they just don't know what to say, right? You're a physician who's not typically seeing cancer, right, all the time. And there are wrong things to say to cancer patients, right? And so I think it's not that they're not empathic or empathetic. I think that it's that they don't see enough of this to realize that those words are harmful. So I think education goes a long way. So any doctor that tells you, oh my God, you have thyroid cancer, great, that's the one I would pick if I had cancer, call them out, right? Just like you call people out when they say anything that doesn't feel right. So I don't think it's that they don't care. I think it's just that we need some education, right? Thank you for a great presentation. It's very helpful. Oh, that's nice. Thank you, Neil. Newly diagnosed medullary thyroid cancer here. This solidifies my plan to get a second opinion. Now just trying to decide where to go. So in deciding where to go, right, there's several things that one wants to think about. And thank you for your kind words, by the way. That, is who are physicians that see medullary thyroid cancer. Medullary thyroid cancer is very rare. Right? Did I get the right treatment? Am I even checking the right markers, right? Are there, are the right things even being checked and follow up? It doesn't mean you're not going to end up following up with your doctor, but getting that opinion to make sure everything's okay, being comfortable and going back is okay too. When you can start with looking in your health plan who they cover for thyroid cancer, and then looking them up to see if they've seen medullary thyroid cancer. A lot of times you go and you ask your doctor, like, oh, you're the only patient with medullary thyroid cancer I've seen. Doesn't mean they're going to do a bad job or they're wrong, but it may make sense because it's a rare tumor. See somebody and make sure it's the right plan. Okay, for the rest of my life, what should I be doing, right? Or what's the treatment plan? And when do I come back to you? Oh, well, if your calcitonin, as an example, calcitonin and CEA are undetectable, ultrasound the next being done, everything looks good, you're followed for life, great. If your calcitonin bumps or CEA bumps, or they see an indeterminate nodule, just come back to me. Let me see what it is, or something, right? They'll be helpful in doing that. Now, some places, I didn't bring this up in my presentation, will give a second opinion by video telehealth. Now that video telehealth, one good thing that came out of COVID is many people are accepting telehealth. And so sometimes you don't even have to travel there. Just ask them for that second opinion in writing or by video. And get it and see what you're comfortable with. So sometimes, like Barb was mentioning, you get a second or even a third because you're still not sure. So try and go to places where people have seen that cancer type quite a bit of. And now, you know, that we have internet, Google can be very helpful. This is a fairly specific question, so I apologize in advance. Oh, but it sounds like you're okay for us to read it out loud. I have type 1 diabetes and pre-established relationship with an endo who specializes in diabetes. Perfect. Given my recent thyroid cancer diagnosis, my endo is also treating me for thyroid cancer and managing my synthroid. Perfect. But admits she's not an expert in this area, and I have not loved her advice on my cancer treatment thus far. I'm sorry about that. Do you think it's worthwhile to seek out an endocrinologist specifically for thyroid cancer and maintain relationships with 2 endos for my 2 concerns? So yes, absolutely. That happens all the time. So you need a diabetes specialist for your type 1 diabetes, because again, type 1 is very specific and rare, and you're, if happy with your care for your diabetes, fantastic. You're not so happy. Now, the endocrinologist is perfectly capable of treating and following you for thyroid cancer, but you're not comfortable, or they may not be doing things right, or whatever the concern is. So it's okay to go seek a second opinion for your thyroid cancer. Tell them I have an endocrinologist who takes care of my diabetes and my thyroid cancer. I'd like to come see you for a second opinion. And you get that. And let's say you like what this other person is saying, right? And so you're fine with it. So it's okay to have 2 endocrinologists. So as an example, I do that. I don't do diabetes anymore. Back in the day when I started 20 years ago, I used to do both diabetes and thyroid cancer. And I quickly realized, you know, all these fields are changing, both diabetes and thyroid cancer. And so I chose to continue and do thyroid cancer only. So I have patients who have diabetes, and I say, keep your endocrinologist, let them treat your diabetes, right? And I'm going to treat your thyroid cancer. And if we need to talk, we'll talk, but otherwise, and you're clear and you're open with your doctor. So absolutely that can be done. And yes, typically your insurance will still pay for it. I have Herthel cell, 2 surgeries in the neck, rising thyroglobulin, which doubled in a year, radioactive iodine resistant. Thyroglobulin rose after 200 millicuries in March. Now 10 millimeter lung nodules up from 7 millimeters in a year. Suspicious area in the iliac crest. Recently biopsied, what was negative. Endocrine in a large teaching hospital thinks it's possible the biopsy missed the lesion. They're presenting my case to tumor board next week. Considering, external beam to one or both areas, hip and lung. No targetable mutations. Just wonder if an outside second opinion might be helpful. Okay, so this question is fairly specific, but I think we can generalize it to other people. So in general, Herthel cell cancer doesn't have biomarkers or mutations that have a targetable drug. So that's what they're telling you there. And Herthel cell is frequently resistant to radioactive iodine. Thankfully, though, for Herthel cell, you typically still make thyroglobulin. And so it still stands as a good marker, despite being radioactive iodine resistant. So if you have a small lung nodule that's grown a little bit over a year period, and then you have a questionable area in the bone, sometimes people will actually, so this is somebody that should be discussed in a tumor board. Sometimes people will say, okay, well, this has grown in a year, but thyroid cancer has a different slope of growth, right? So thyroid cancer, sometimes you have a spot that's there. Sorry, I'll start over here. You have a spot that's there, and then it grows this visit, and then it stabilizes next 2 visits, then it grows next visit, then it stabilizes. So the slope of that growth took a couple of years, right? Or was 2 or 3 millimeters in a year. So it wasn't too much. On the other hand, and so that patient may not need any treatment except TSH suppression and observation. Now, they may decide, well, I want to do localized therapy. This patient doesn't have bulky enough disease that needs systemic or targetable therapy, or kinase and general kinase inhibitors, but I want to do localized therapy, which is very often done in thyroid cancer. So I want to zap this with stereotactic radiation, which is 1 or 2 days of radiation at high dose, localized, less effect to surrounding tissue, or I want to zap the bone. Now, the thing is exactly what you're saying. Why many times we don't biopsy bone lesions is when you try to biopsy, you often will get negative either because they couldn't decalcify it or because it wasn't in the tumor. So it's very hard. So if I see a small bone lesion, I often will just watch it. If it's not painful, not in a location that is in a weight bearing where I'll get orthopedic's opinion. If it's small like that, I'll often just watch it. It doesn't mean you don't radiate the lung. There is a role to radiate both if both are growing, but you can have benign bone lesions that show up. Right? And you can have lung nodules that show up. And so that tipping point is something discussion for a lot of, and applies to a lot of people probably in this room, is that it's constantly a discussion. When do we start systemic therapy? When do we radiate? And sometimes I'll wait a couple of times to prove that it is going to continue growth and that the slope of that growth is every time they come, something's growing, which is like this, as opposed to a slope like the more gentle, right? More flat, which is it grows a little bit, stabilizes, grows a little bit, stabilizes. And those people I tend not to treat right away. So again, that's not for you specifically. I was trying to make that general. Your question was, should you get another opinion? So yes, you can get another opinion. It sounds like your doctors are all thinking in the right direction, but it doesn't harm. You need to be comfortable. So you could say, let them do their tumor board and okay, they recommend radiation. Let me go get this opinion, see, should I do it now or later? And they may not agree, but you can make your decision. So that may be a time to get it, unless you're comfortable with it. In general, are all endocrinologists well-equipped to manage non-advanced differentiated thyroid cancer? My wonderful doctor moved across the country and I'm feeling less confident in my new team. Their practice seems less focused on thyroid and more on other endocrine disorders. So it's very common that you'll have an endocrinologist that doesn't do thyroid cancer because there's a lot more diabetes than there is thyroid cancer. And so just because they've only seen a few cases, doesn't mean that they're not going to do a good job. But at the same time, if your case is a little more advanced or recurrent, or you're just not as confident as you say, it's okay to get another opinion. But if the practice is, overall you're comfortable and they're doing a good job, just because they haven't seen a lot of this doesn't mean that you have to go get another opinion. But yes, so we cannot generalize and say all endocrinologists are well equipped to manage non-advanced thyroid cancer. Many of them have never seen a case and may not be comfortable. So for example, even if you have, so we're talking about non-advanced differentiated thyroid cancer, you have a 1.5 centimeter papillary thyroid cancer. It's not going outside the thyroid. It's not in lymph nodes. It's there. You may ask me, should I observe this or take it out, right? That wouldn't occur to a lot of people because they're like, oh my God, it's cancer, take it out. But somebody who's more, who sees a lot of thyroid cancer may be more comfortable with that. And, there are studies now, observation studies internationally and locally that have shown that if you have a 2 centimeter papillary thyroid cancer or smaller that's localized and not have spread, that they have, especially, and you're older than the age of 40, that the tumor may not grow and it's okay to watch it with ultrasound. So I have actually a practice of patients that I see that we never operate. They don't want surgery. They don't want the chance of going on thyroid hormone, and it's not growing. And if and when it grows, we operate. So my point in telling you that is no, not all doctors can handle all things, right? So not all endocrinologists are well equipped, but it doesn't mean that they can't do a good job. So I'm being very careful on purpose in that it's okay to get another opinion. It's okay to stay, but it's also okay to stick with yours. I fall into the 5% with follicular thyroid cancer with multiple recurrences and surgeries, radioactive iodine treatments of 600 millicuries and focal radiation over the past 12 years. We are happy with our care team, but should this be something where we should get a second opinion? Okay, so I think that it's complete. So if you have, basically you're saying you have the rare tumor, you have advanced disease, resistant to radioactive iodine, and you've had some radiation. If you're happy with your care team, you don't need, yes, even though it's rare, so it was on the list of people that can get a second opinion, you don't have to get a second opinion because there's some people who get excellent care with their care team. Not everybody, just because it's rare, gets a team. So I was not trying to imply that. Hopefully that was okay. I'm being seen by otolaryngology surgeon, an endocrinologist fellow, a senior endocrinologist, and a genetic counselor. Wow, you have a whole team. Great. I find it hard to manage the situation. Oh, they don't always share the same opinions, and sometimes it feels like they don't coordinate. Appointments are used to deliver news, which I can't always process on the spot. I push back, but they give simplistic answers that don't help me process things. Any thoughts on how to manage the situation? So this person's issues are not uncommon, unfortunately, right? You have a multidisciplinary team. They all probably know what they're talking about. But again, not all of the treatment algorithms for thyroid cancer are 100% agreed upon because there is room to manage things differently. The problem is when your care team doesn't agree. So your care team ideally should coordinate. I think it's okay for you to suggest that they coordinate and say, and go to the one you trust the most first, right? And say, even if it's the fellow, right? And tell them, I hear what you're saying, And I tend to agree with you. I'm a little confused because, you know, I'm no specialist, I'm no doctor. And I hear this is what I'm hearing from my surgeon. This is what I'm hearing from the endocrinologist. This is what I'm hearing from you. And I'm not in any way implying that one of you is right and the other is wrong. I understand that in medicine, it's, you know, not like a perfect physics or science because we're humans, but I need help processing this. And I need your help to tell me, you don't necessarily have to decide what I do, but tell me what the right thing would be. So sometimes patients approach and say, what would you do if you were me? So my thing is I step back and I say, I'm not you, right? I'm not you because I don't know what's going on in your background and your family and quality of life and what it would mean, for example, not to have a voice box or to have a trach, but I can tell you that this and this and this will happen with this treatment and this and this and this will happen with this treatment, and there isn't a right answer, and this is why. Now, if you're the type of person that this is what I would do, but I'm being clear that I'm not you, right? So I think that that's how I would handle it, is I would go to one of them and tell them what you're hearing, even take notes, what you're hearing from this person, what you're hearing from this person, and how they suggest you handle it. And they can potentially, hopefully take the lead and say, okay, I'll talk to them. Right? And help you process. I'm so fatigued and my endocrinologist has been awful. Hospital system totally forgot post-radioactive iodine thyroglobulin tests during my inpatient treatment. Where do I go from here? 27 years old, 7-centimeter tumor, PTC with 20 cancerous lymph nodes being involved. So you have defined the need for a second opinion, right? You're not happy and you feel bad. So you look up who potentially knows some in your area about thyroid cancer, so it's not too far for you, and request a second opinion, right? And I'm so sorry that you're not feeling well, and I do hope you feel better, but this commonly, unfortunately, happens, and you hopefully will see somebody and get the help you need. And if your fatigue is not from your thyroid cancer and not from your, thyroid hormone, then hopefully that endocrinologist or the second opinion you're going to go get can help give you ideas of where you should look, right? So that unfortunately happens, but hopefully you'll feel better. Could you address the importance of your doctors being fellowship trained? Okay, so every doctor goes to medical school, either DO or MD school, okay? And after that, they have to do at least 1 year of like an internship, okay, to get licensed in most states. After that, if they're an endocrinologist, to be called an endocrinologist, you had to have done 3 years of internal medicine and then 2 or 3 years of a fellowship. So the internal medicine is called a residency, and fellowship means that they did that subspecialty. So in endocrine's case, you cannot be an endocrinologist without doing a fellowship in endocrine, okay? Now, if you're a surgeon, you can do general surgery and operate on thyroids, and you don't do a fellowship. So you did the residency of general surgery, but you do thyroids, okay? So there are some guidelines as to whether your surgeon is, good and competent to take care of thyroid cancer, that they should have done at least 100 of those a year. At least 100 of those. So they don't have to have a fellowship as a surgeon. Now, as a surgeon, you could do ENT, which again is a residency, but you can do head and neck surgery fellowship. So a fellowship implies some sort of subspecialty. You cannot be an endocrinologist without fellowship. You could be a surgeon and be perfectly fine without a fellowship in head and neck surgical oncology or endocrine surgery. Okay. And then as an oncologist, you are automatically fellowship trained, because an oncologist did internal medicine 3 years and then did oncology for 2 to 3 years. Okay. So oncologists and endocrinologists have to be fellowship trained. Surgeons don't. Hopefully that answered your question. I had Hürthle cell cancer and have been monitored by my surgeon, but he is retiring. Who should I look for continued monitoring? So, I tell my thyroid cancer patients that they need lifetime follow-up. So by ultrasound and blood work, now at some point they can go to every other year ultrasound if it's been years of no thyroid globulin antibodies, and no ultrasound, and nothing on ultrasound, but it's a lifetime. And the reason for that is with other cancers at 5 years, the risk of recurrence is on the floor and it doesn't tend to come back. But with others, with thyroid cancer, you can have a recurrence at 20 years. So I'm not saying that to scare you or to be negative, but hey, follow up, right? You can be in survivorship clinic, you could be in, ultrasound. So now that your surgeon was following you is retiring, hopefully they're still around, you can ask them, who do they recommend? But you could go to an endocrinologist, If you have a good primary care doctor who knows what to monitor and has a good radiologist who does ultrasounds, you could consider that. But just be careful that they understand Hürthle cell cancer, which is most primary cares typically don't. So I would probably get an endocrinologist. Thank you so much. Oh, that's nice. Thank you for your kind comments, all those that are commenting on the talk and on my comments. I found many endocrinologists don't have enough knowledge to appropriately give follow-up care for more nuanced, non-standard cases. That's probably true. How do we ensure our endocrinologists have the appropriate knowledge to treat us? What questions should we ask? So that's great. Actually, I think on the ThyCa website, they say, what questions should I ask my endocrinologist? And on the American Thyroid Association website. So a good place to start was to get a good basic list of questions, because that's a great question, Lauren. Like, how do I even know if my endocrinologist knows what they're doing, right? So, if you ended up, you don't have, let's say, a standard case, or even if you do, if you get a second opinion, but are okay following with your first doctor, then from that second opinion, say, okay, how do you know, you're an expert in thyroid cancer. How do you follow up thyroid cancer? What should I be asking my doctor? And, so I'll tell, for example, I'll tell you, oh, well, because you have a spot there, you should be getting every 6 months ultrasound and thyroglobulin antibody, and the TSH should be between 0.1 and 0.5 for your stage of cancer, right? So you wrote that down, you go back to your doctor and you're like, okay, if anything seems off, then I'll tell them this is what I think should happen or whatever. But in general, questions you want to ask your surgeons, like if they see thyroid cancer, the endocrinologist see thyroid cancer, are you comfortable with my case? Or do you feel like a second opinion? It's okay for you to ask them what their opinion is, how often they see, and then in general for follow-up care, ideally, if you look at the American Thyroid Association guidelines for thyroid cancer are very long, but there some parts you can actually in a PDF just search for like follow-up care, and it'll say in there annual or 6 month, or there's a range. So that may be helpful to you if you're looking for, okay, what am I expecting, and how do I make sure my doctor's doing this? So either a second opinion with it by an expert and then going back, or looking at the guidelines. I'm so fatigued and my endocrinologist has been, oh, I think we read this one and I forgot to click. Okay. Thank you so much for all this info and your care. I have a question on the notion of a care team. I was recently diagnosed with papillary carcinoma less than 1 centimeter, or what we call subcentimeter, and have seen many of the specialists you've mentioned repeating details and questions. The endocrinologist I'm working with, oh, I see, you as a patient have to keep repeating things. Yes, we'll talk about that in a second. The endocrinologist I'm working with is great, empathetic, and open to my preference for active surveillance for now. Great, but there is no care team as far as I know. How to have or cultivate one? I've had referrals to doctors in different offices and practices, including to a thyroid surgeon who's mostly behaved quite differently, i.e. authoritarian from the endo. Second opinion will be in 2 weeks. Would love to experience working with a care team and deeply appreciate your guidance. Okay, let me address this one by one. So first of all, you have, it sounds like a small thyroid cancer that's intact and not been removed. And you're found a doctor who's good and open to your idea of active surveillance, which is one of the options for small thyroid cancers, to be watched and surveilled, depending on where it's located. So that's great. Now, if you have a small thyroid cancer and they're doing a full neck ultrasound, remember ultrasounds, you probably heard in the other talk, should be of the full neck, not just the thyroid, right? You want to make sure the lymph nodes all laterally and back have been looked at. Even though majority of thyroid cancers go to the lymph nodes in the front, they can go here too. So you want a whole neck ultrasound. So let's say you've looked and all they see is this and you want to watch it and they're happy watching it. They follow your TSH, put that in the appropriate dose. Then you don't have to have other people. Now, I usually say at the beginning, get a surgeon and an endocrine opinion, which sounds like you did, right? The reason from that surgical opinion is also because the surgeons know the anatomy. So it's good to have more than one doc, right? Now, there are some surgeons who don't believe in active surveillance, right? They're a surgeon, they want to cut it out. And there are other surgeons who believe in active surveillance, right? And so you've identified a surgeon who's trying to say, this is what should be done, forget everybody else, because maybe he's seen a patient with thyroid cancer who went badly, right? But I think that it's unfortunate in how they're talking, and that conversation, because of course your treatment team has to be comfortable with your decision as well, right? You can disagree with them. So it's okay for you not to necessarily, you would be more comfortable if you saw a surgeon. And the idea from the surgeon is to know that the location of where it's at is not in a place that if it grows, it'll get into trouble in my voice box or what have you. So there are caveats listed out in all these trials that were done for observation in people who had small cancers that were observed that didn't need to go for surgery. If they were in a specific location, then observation was not okay, but for the vast majority, it was okay. So the reason for the surgeon is to make sure that everybody's in agreement. Now, so a second opinion from another surgeon would be okay. But if you're comfortable and your endocrinologist is comfortable, I'm not saying you have to have multiple doctors, right? Every time we see a doctor, we have to wait in the waiting room. We have to pay another copay. So I'm not saying in an ideal situation, you're seeing 5 doctors, right? But when you have a more advanced case or you have doctors disagreeing, then having another opinion can help, at least for a one-time visit. I have a 2 centimeter and a 1.1 on my right lobe. Biopsy showed malignant and highly suspicious. On my left, I have a ThyRads 4, 5 millimeters. One surgeon is advocating half, the other is advocating patient choice. One surgeon wants a CT scan. The other says straight to surgery. Should I get a third opinion? Yeah, so this is what others were alluding to. It's hard when your team doesn't agree. And so sometimes getting a second opinion is more confusing than just having the one opinion. And so you have thyroid cancer on one side and you have a questionable nodule on the other side. And so there is some controversy whether you remove half and observe. And I talk to patients about, there isn't a right answer in like, oh, total thyroidectomy, right? So sometimes in the guidelines, it'll say if you have multiple nodules, that's an indication to consider a total thyroidectomy. But again, you don't have cancer proven on either side, right? Oh, no, sorry. You have cancer proven on one side and the other side, it's unclear. And so you can also do what's called stage surgeries. So you can remove half that has the cancer and follow the other half with ultrasound. An advantage of doing half is potentially less complications, 50-50 chance of needing thyroid hormone, right? So it is, I can understand why one is saying half and the other one's saying it's up to you. At the end of the day, it's always up to you. But what they're saying, you know, the question always is, if I remove this half and this is cancer, then what happens? Well, you can watch small cancers, right? But you're not saying goodbye, you are going to be followed. So you can repeat an ultrasound. If a year from now it grows, you can always take out the other half, right? So it's not a be all and end all. I think that one surgeon's advocating half, the other one is saying it's your choice. So they're not saying it's wrong to do half. So it sounds, you know, like it's okay. So the only reason to get a third opinion is if you want 2 out of 3 to say the same thing, but it doesn't sound like they're saying different things. So I think it's okay. Sometimes a patient can be overwhelmed by information. Absolutely. How do you feel if patient requests recording the visit? I don't think it's a problem. I think it's much more courteous if the patient, I have patients who haven't told me and I just see it. I mean, I'm an intelligent person. I can see it out there. It's, you know what I mean? But I think maybe to be fair to that patient, maybe they've been burnt. They asked somebody else and then that other doctor had said no. And so they didn't want to give me the option to say no. I just think it's always nice to tell your doctor, hey, and be open with them. Say, you know what, it's overwhelming. And I always advocate patients bringing someone else with them. Now, in COVID, most hospitals weren't allowing a visitor, right? So it was very hard. So I told every patient that came by themselves to bring their family member on FaceTime or on the phone so they could answer questions. It always helps to have somebody else with you. Now, I think recording is fine. I think taking notes is fine. I just think it's courteous if a patient asks for permission. That's all. What is the role of my primary care doctor in my care? Thank you so much. So thank you. It depends on the primary care. So a lot of primary cares, once you get thyroid cancer, are hands off. They say, I don't know enough about thyroid cancer, but there are primary care doctors who are very knowledgeable and say, hey, you know what? You know, follow your endocrinologist, but I want to, you know, I'm happy to help with some of the thyroid hormone management, and I want to help with, you know, this part. Ideally, those two talk. Again, I'm realistic, and I know that doesn't always happen. So what I tell my patients I'm an endocrinologist, and they're seeing their primary care, and the primary care has adjusted their thyroid hormone, is usually my nurse or myself, they get the talk about too many cooks in the kitchen, right? So if you have too many doctors handling the thyroid hormone, it gets overwhelming for the patient. So what I tell them is, it's okay. You don't don't have to fight your primary care doctor. If they want to adjust your thyroid hormone, send me a MyChart message and say, hey, this was my latest TSH. This is what my doctor's recommending. What do you think? And I will answer honestly. And I'll say, you know what? It's okay because you have this symptom, or from a thyroid cancer standpoint, this is why you need it. So I would favor you stay here, right? So that way, indirectly, you're having the docs communicate. Usually primary care doctors don't get involved with the ultrasound follow-ups and don't know about thyroid globulin. So that's why it's good to have that endocrinologist in general. Fantastic discussion. You're so knowledgeable. Oh, thank you. So kind. And are clearly passionate about what you do. I wish I lived closer to Houston so you could be my specialist. Thank you very much. That's very kind of you for your comment. My story reinforces your recommendation for lifetime follow-up care, which is something I did not have. I had thyroid cancer at age 19, papillary cancer at age 46, and anaplastic thyroid cancer at age 71. Wow. I'm really sorry, Ina, but I did see that earlier you told us you're in remission. So I'm so happy for you because that's so rare and anaplastic, but I 100% agree with you. Lifetime care for anybody who has thyroid cancer is key. And, you know, this story at age 19, if a doctor had told you that, oh, thyroid cancer is the good cancer, where would you be today? Right. So, you know, hopefully your doctors don't say that. And yes, advocate for lifetime care. Even if your doctor says, oh, you don't need follow-up anymore, find somebody who's willing to follow up with you. So I think that's all the questions, guys. If anybody else has any questions, you have about 2 more minutes. But I really want to thank you guys for being such an engaged audience. It's been awesome. And especially, you know, on Zoom, it's really hard. And when we're in person, it's a lot easier and we can see and see each other and talk even in private. But you guys have made this really amazing and engaging, and I really appreciate it. So thank you to each and every one of you. And I hope everybody enjoys the rest of the ThyCa conference. Sorry, Barb, to interrupt.
No, wonderful. Thank you so much. Yes, I think we're out. If anyone, they can always obviously email us or check back on the recorded sessions if you have a question on one of the other sessions. But thank you so much for your time and your information. And again, thank everyone for coming to the conference, and enjoy the rest of the weekend. So thank you very much.
Thank you, guys. And thanks for all your beautiful comments. I didn't read all of them, but I appreciate each and every one of you saying kind words.
Thank you.
Thanks, Barb.
Thanks. Bye-bye.
Bye-bye.